Committee on Health and Human Service Finances will come to order. We do not have a quorum. Representative Davids has House File 3543. Representative Davids, do you want to begin by presenting your bill?
Thank you very much, Mr. Chairman and members. What House File 3543 does, it takes several actions regarding health care, MNsure. Section 1 puts the operation funding from a maximum of 3.5 down to 2%. And I remember clearly, like it was yesterday in committee when MNsure was going through the process here, we were promised in Commerce Committee, Mr. Chairman, that the price would not be above 1.5%. So I suggested that we put that in the law. Well, there's some pushback on that, and it went to 3.5%. And of course, I think they had maybe 1 or 2 years at the lower rate, I think just one, and then they went up higher. And so now they're charging a higher amount on higher premiums. But of course, there are fewer people than they had projected to be on this. So that's Section 1. Section 2, health care and health plan requirements. Section 3, limitations, very important on risk bearing so that the Department of Health cannot become an insurance company, as the governor is proposing in the, I guess I'm carrying that bill. I'm carrying the governor's bill that would do that. I guess we'll have to work on that. And Section 4, expanded access to qualified health plans and subsidies. And then rates for individual market health and dental plans for 2019 requires health carriers when setting rates for individual health and dental plans for 2019 to take into account the reduction in premium withhold percentage. So members, I think we'll certainly answer any questions you'd have on the bill, but we have a packet of dueling letters today, and I would just like to address that. You should have a letter from the Department of Human Services from Mr. Acting Commissioner Chuck Johnson, and I'd like to point out just a few things in that letter that I would respectfully disagree with. First of all, it says in the first paragraph, as it would prevent Minnesotans from accessing affordable comprehensive health coverage on the individual market. I'm not sure if that's with Minnesota Care or if that's through MNsure. Of course, we do not need MNsure at all. We could use the federal exchange. It does not affect people getting subsidies. This bill prohibits Governor Dayton's Minnesota Care buy, and I want to be very clear, that is very, very accurate. But the part that's not accurate, it says, which proposes a new comprehensive affordable health insurance option for Minnesota. And you'll see that they have already gone up from their projections last year. I don't know what it's $400 some or $500. It's up to $659 for the silver plan in my area because I have higher rates. It probably in statewide be about $8,000 a year per person. In my area, probably be about $12,000 a year per person. So to say that that would provide affordable health insurance, I guess it depends on the definition of affordable. And then you go down in the second paragraph a little bit lower there, it says enrollee premiums paid to DHS would be sufficient to fund coverage costs. Well, how do you get there? You get there by cutting providers. That's a huge concern of mine, that you will actually be limiting coverage because you'll start having providers not accepting Minnesota Care in their clinics and hospitals. And I'm very, very concerned. There's a lot of stress on rural hospitals and clinics today. This would just make it much worse because the reimbursements to get into those price ranges would have to be much lower. And then you can see that there should be a letter being passed out to committee members where I kind of rebut what my good friend Acting Commissioner Chuck Johnson has said. So members, I don't know how much you want to get into the MNsure thing. I'd love to talk about that all day long. But first of all, we cannot have the Department of Health being an insurance company and putting things at risk. And when the letter from Mr. Johnson says that enrollee premiums paid to DHS would be sufficient to fund coverage costs, well, that's not really true because they're asking for $120 million in the bill that I'm carrying. Wonder how that'll go. $120 million to set it up. So they, if you can't cover the costs, then of course you go into the reserve. So it did not cover it because if it would cover it, why would you need the reserve on that? So Mr. Chair and members, when Obamacare passed, the public option was too extreme for even Democrats in D.C. When MNsure was passed by Democrats, the MNsure public option was too extreme for Democrats in Minnesota. If it is wrong for MNsure to act like an insurance company, why is it right for DHS to act like an insurance company? I really don't think we want to go there. Calling the public option a real plan is an insult to people who were ruined by Obamacare and MNsure. The public option requires at least 3 different federal waivers in order to even be offered in Minnesota. Is the Trump administration going to grant those waivers? A 70-30 public option plan will cost the individual at least $8,000 a year. That's not a solution. That doesn't help anything. If premiums don't cover medical claims and administrative expenses, one of 2 things will happen. Taxpayers will be on the hook big time, or the public option plan will not be accepted by providers anywhere. Cutting medical reimbursement for 100,000 people will devastate rural hospitals and clinics, further jeopardizing access to health care in greater Minnesota. From 2014 to 2016, DHS failed to collect tens of millions of dollars in Minnesota care premiums because of bad technology. Given the failures of Health Match, MNsure, MNlars, how can we trust the public option to actually function? So my bill takes care of a lot of those issues, and I'd appreciate the committee's support.
All right, thank you, Representative Davis. We do now have a quorum, and Representative Albright moves approval of the minutes from March 22nd. Any additions, corrections? Seeing none, all those in favor of adoption of the minutes from March 22nd, please say aye. Aye. Those opposed, no. The minutes are adopted. And Representative Davids, I will move that House File 3543 be referred to the Committee on Taxes. The bill is before us. Questions? Representative Lunan.
Thank you, Mr. Chairman. More a statement than a question. One of my concerns with public health care is the cost shifting. The medical providers get reimbursed, and in Medicaid, get reimbursed at a rate that sometimes is below what their actual costs are. And the wink-wink deal that's cut with them is that they are allowed to cost shift, and those losses to the providers end up getting shifted over to people that have private pay insurance. That's why you go to the emergency room, the first question you will be asked is not, are you okay? It's, were you at work? The second question you get asked is not, are you okay? It's, were you in a car? And the reason for that is because there's no fee schedules in those coverages, and it gives those providers an opportunity to cost shift the under reimbursement procedures that they've gotten through MA over to those situations and handle that. This would be more palatable if viable if the cost shifting didn't exist and everyone would go by their own merit, but this literally would be funded by the private market that we have right now, and I agree with the author's case that government does not belong in health care.
All right. Representative Pinto.
Thank you, Mr. Chair. Chair Davids, I'm wondering the premium withhold, the drop from 3.5% to 2%. What is the premium withhold on the federal exchange? Because my understanding is that that is still that higher, 3.5%. So if part of the thinking is to push folks to the federal exchange, wouldn't they be just at that same 3.5% premium withhold?
Thank you, Mr. Chairman. Pinto, maybe we could go to Mr. Chun or staff to see what the federal is.
Mr. Chun.
Mr. Chair, Representative Davids, I'm sorry, I actually don't recall. I think it's about 3 or 3.5, but I don't recall. No.
Thank you, Mr. Chairman. That makes me feel very good. If he's not sure, then I don't feel so bad about not being sure.
Representative Pinto.
Thank you, Mr. Chair. And Chair Davis, I guess it so it seems like that's probably worth. So I guess we'll get that information. But my sense is that it is perhaps that higher number. And so what we're doing in this is it seems to me anyway, starving a system that, or moving in that direction anyway, a system that actually has been coming off of record enrollment of serving consumers, making improvements, and actually forcing it to operate with, and percentage-wise, what is that, like maybe 60% of the funds that be coming into the federal exchange, 2% being 60%, approximately 3.5%. And I guess I have some considerable concerns about doing that. And then the other question I had is, if the proposal is to have individuals be able to get the tax credits outside of MNsure, I have the concern, it seems like MNsure would still have to do the eligibility determinations even for those individuals outside of MNsure. Is that correct?
Well, Mr. Chairman, that's the way I understand, but I think of MNsure, I like to watch movies, and there's a movie with Bruce Willis called The Sixth Sense. He was dead, he just didn't know it yet. And I'm really thinking that's the case for MNsure. I don't think MNsure is going to be here that long because, you mentioned, Representative Pinto, starving the system. If it takes about $500 to $600 million to starve the system, it looks like me, if you think about it. Because it's not starving. We have thrown, if you think Midlars is bad at $100 million down the drain, try MNsure at about $550 million down the drain. I mean, people are up in arms about Midlars. I'm saying, look at MNsure. What's the deal here? Now, as far as record enrollment, record as compared to what? We were promised 450,000 enrollees in the individual market, about 150,000 small businesses, and they get maybe over 100,000. That's like having me be a high jumper, and you put it down to 2 inches, and I clear that, and then I come back for my next run of 3 inches, and I clear that, and I set a record. So record enrollment, that's quite stunning to even consider that when we were promised 450,000 enrollees, and what is it, about 100 or 100 and something, and it's just very sad.
So, Mr. Chair.
Representative Pinto.
Thank you. It's my understanding, Chair Davids, is that the number of Minnesotans without insurance has dropped in half over the years of MNsure. So I kind of wonder, with respect, it may be the opposite of the Sixth Sense. Maybe that you're looking at it thinking that it's dead, and actually it's very well alive and thriving, and seeming to do quite well. But I guess my question was about the eligibility determinations, because if MNsure still has to do the work to determine eligibility, but people are getting the credits and doing things outside of MNsure, then basically it's requiring it to then provide a service where the funding is not coming in to support that service. Actually, 60% of the funding the Federal Exchange would get. So I guess that's where it seems to me that it's, if you're forcing it to, having it do that service, not provide that support, it seems like it's, that is where you take something that is, and I guess with respect, I'd say alive and thriving, and pushing it in a direction that may be real harmful for Minnesotans, because we don't want that rate of uninsured Minnesotans to double back to where it was before MNsure came along. So I do have great concerns with the bill, Chair Davids and Mr. Chair.
All right, Representative Loeffler.
Well, thank you, Mr. Chair, and Representative Davids, I really respect that you work a lot with private insurance, and your knowledge in taxes is really impressive, but you don't get to spend as much time in this committee as some of us do. And so I think maybe some of the impressions that you've got are a little dated. And I'll just tell you from my own experience, the first year of rollout of MNsure was rough. And it was rough across the nation because there was not enough lead time for anyone to do what was needed and expected in the time frame that was needed. I have not in the past 2 years gotten one single complaint from anyone who used MNsure to either purchase private coverage or to access our public programs. I have, in the this last winter, I spent 2 evenings at an enrollment site in 2 different places in my district, and all the people who came in there were very happy and were able to be served that night in a reasonable amount of time with some assistance from a trained navigator. And I've heard really wonderful things from people in my community who used to have very high deductible policies that basically meant they felt like they had no health care because they couldn't afford the $10,000 or the $15,000 that you'd have to pay in addition to your premiums. And when they found that they were eligible for Minnesota Care for the first time, they were able to get caught up on some health care needs that needed attention. And so I think that, we have got a system that is working right now and is meeting the needs of people and is relieving providers of a lot of debt. And I've been actually asking to get information on how much uncompensated care increased with these high deductible policies, where the providers are saying they're spending a lot of money on collection agencies that oftentimes can't can't even bring in 20 cents on the dollar because the people who have these high deductible plans are living paycheck to paycheck, and even if they're making a small payment towards that debt, are never probably in their lifetime going to be able to relieve the full cost of a serious medical cost. And so I do think that we need to think about how serving people through these programs has actually reduced the provider's cost in debt collection and uncompensated care, and I've heard that from providers in my community. So I just wanted to give you some background from my personal experience. But then I do have a question on your provisions that would prohibit the Commissioner of Human Services from having Minnesota Care programs purchased through the MNsure website. What do you define as purchase? Because if someone enrolls in Minnesota Care, they are repaying premiums. They are disproportionately working. It's a sliding fee premium system, so they are purchasing with that premium payment. And was it your intent that, how would you see Minnesota Care applications being, in the current system, being able to work under your current program?
Representative Davids.
Well, thank you, Mr. Chair and Representative Loeffler. What I'm looking at is not, if you look at the bill, it's to not expand Minnesota Care. So I don't know that that would really change. But a couple of things. I'm very happy that you've had good luck with MNsure. I've had quite the opposite. I think of a couple that I know that he's 63, and I just tell these people, you got to get to 65 as soon as you can. And she's 59, and they're paying $2,700 a month with a $10,000 deductible. Do the math on that. That's not working good for anyone. Now, yeah, if MNsure has someone that qualifies for big public subsidy and it's free, I mean, hey, free is good. Or greatly reduced is good. And I believe the Federal Exchange, and I'll verify this for Representative Pinto, but I think they're at 2% right now. But I'll get that verified for you. As you look at it, why are we allowing, because 3 years ago rates went up 40% on average. 2 years ago they went up 67% on average. So that's a 107% increase. So they're at 3.5% of 107% more. That's a huge windfall. But the problem with MNsure is that they don't have any enrollees. They got about 100,000, and they said they'd have 450,000. That's the problem why the numbers aren't working here. So thank heavens for the reinsurance bill that has leveled off premiums. That has worked beautifully. And even though people, as a rule, the rates were flat because we didn't have the 25% rebate, people, even with a flat premium, got a 25% increase. So huge premium hikes, a windfall on the people that are paying the premiums. And I believe one point was made about the uninsured rate has actually gone up 50% in the last 2 years. It's gone up, and we'll verify those numbers for you. And 70% of MNsure folks are on high deductible plans. So you might have a health insurance card, but you don't have health insurance because you're not going. And I believe that MNcare would stay the same for the people that are on it. Or do I just totally get rid of it? Oh, you're I'll get those answers to you very shortly.
And Representative Loeffler, I believe the bill reads that if you're on Minnesota Care and you want an exit out, you can get an emergency exit out, and that's the way that I read it, but that you could still purchase it through the existing way if you so chose, and I can be corrected if I'm wrong, but I believe that's the way the bill reads. Representative Loeffler.
Well, thank you, Mr. Chair. And I would just say, before we began MNsure, our uninsurance rate was around 12%. And while we did get it down to about 4.3%, I think now the most recent numbers are about 6%, so it has been climbing up. The main reason has been small employers dropping coverage is one of the main reasons, as well as some individuals deciding that with the high deductible plan, they're not really feeling insured. So there was confusion about the mandate going away at the Washington level, but we are still, even at 6%, half of where we were before. And while the projections were were ambitious for how many people would go through MNsure. I think part of the issue, too, was people didn't realize how many people would go on to the expanded medical assistance, and that, I think, picked up about 125 to 150,000. So there are a lot of variables playing at the same time that changed after some of those initial estimates are. And while I think 6% uninsured is still way too much, our goal should be health coverage for everyone, quality coverage that they can afford. And I think that should be our bipartisan goal. That was the bipartisan goal when Minnesota Care was established. I think we should still take some pride in having what I've heard is the second lowest rate of uninsured in Minnesota, in part because of Minnesota Care. And that while 6% is too high, having cut it in half in a relatively small number of years, with all the changes going on in the environment and healthcare, I think that's important. I think we should also look at the issue of why does Minnesota have a higher saturation of high deductible policies than almost any other state. And I think that is something that our Commerce Committee and our Commerce Department should really look at, because that's not a source of pride to me. We should not have higher saturation of people with outrageous high deductibles that they cannot afford. And somehow we have let that part of our market take over more than other states. And I think that's a policy issue that we in the insurance industry need to confront pretty seriously, because that's not good coverage. Good coverage is coverage that allows you to get the health care you need when you need it without going into medical bankruptcy.
Representative Murphy.
Thank you, Mr. Chair. And thank you, Representative Davids, for coming before this committee with your piece of legislation that is, from my perspective, an extension of what we're seeing happen in Congress under the Trump administration. And not that we're Congress, and thank God we're not, because I do think in this legislature and in the state of Minnesota, we do have a fighting chance to find a path forward for the people of Minnesota. I'm just not sure that this bill accomplishes that. Since the passage of the Affordable Care Act, there's been a steady effort on the part of members of Congress, largely from your party, to repeal it, to eliminate it. And even with all the control in Washington, D.C., they can't do it. And I give a lot of credit to Americans for fighting back and fighting for what they believe in, which is getting access to affordable health care. But they, in Washington, are finding ways to destabilize coverage for people. And we're seeing it in the federal budget. We saw it in the federal tax bill, which this legislature is going to have to work on conforming with eventually. And this proposal, to me, is another example of that, where we're not eliminating coverage necessarily for people, but we are limiting MNsure in a way that it is going to put pressure on Minnesotans and their ability to attain affordable coverage. And I have been now at this work of making sure people have coverage since 1991, so a very, very long time. And after every significant reform that we have undertaken, whether it was the passage of Minnesota Care, the attempts in Washington on the Health Security Act when Bill Clinton was the president, after the 2008 reforms to a lesser degree, and certainly after the Affordable Care Act, we've watched the marketplace try and find its positioning within the healthcare arena here in the state of Minnesota to be able to earn its keep. And I will say that in my many, many years, I have not seen the kind of behavior from the healthcare marketplace like we are seeing today, which gives me a great deal of pause about what you're proposing here, because while we have disagreed and disagreed strongly in this committee over the right way to go forward, and I'm a supporter of, I'm a single payer supporter, I'm a supporter of the Minnesota Care buy-in. I think anybody should be able to buy into Minnesota Care. I think that's a good deal for Minnesotans, and frankly, so do a lot of Minnesotans think that. Efforts to try and limit coverage for people in public options means that they are getting cast out into a marketplace that really is using its tools, and I will name some of them. Using its tools to deny people care. So we're seeing networks that have become so rigid that it is intending to keep providers out and keep enrollees in, and making it hard for Minnesotans to actually navigate and get care where they want to get care. We saw when the individual market started to destabilize and ask a request for and a granting of enrollment caps. That came from the insurance industry. Don't make us enroll too many people because, we might bear some risks. So limit that for us. We are seeing drug costs, inordinate drug costs, being borne by people where they can't afford their medications. And we know about pharmacy benefit managers and Representative Hamilton. I don't know if he's here today, but his fight right now for the drug that he needs for his condition. And we're having that fight here in the legislature, not making a lot of progress. We're seeing hospital systems closing hospitals. And I know you are very familiar with that where you live in the southeastern part of the state. We are, I think, experiencing surprise billing. And I talked to a gentleman at Farm Fest last summer where his wife was hospitalized, but he didn't realize she was hospitalized in an observation bed, and he got a bill for $14,000 that he didn't expect, and he didn't anticipate, and he had to pay. He was, upwards of 80 years old and didn't anticipate that, but his wife needed to be hospitalized. I've not seen these kind of behaviors in the private, in the commercial, in the healthcare marketplace in my 25 years. And it is uncomfortable, I think, to say it out loud. Because, we are Minnesotans and we think the best of one another. But I worry a great deal about what you're suggesting here in this legislation and the net effect it will have on Minnesotans because they will be cast into that private marketplace that I don't think is looking out anymore for the health care of Minnesotans, not in a comprehensive way. And if they're not going to, and I don't think they're even charged with that, then we have to. We have to. We, representatives of the people, have to look out for Minnesotans. And I think that this legislation that you are offering, while I understand why and its roots, I think continues to do the very same thing of destabilizing people's coverage and their access to health care. And that's why I think it's a really bad idea. And I wish that you would withdraw.
Representative Davids, and then we'll go to Representative Gruenhagen. And just remind members that we're going to focus on the how to pay for this sections of the bill, which are section 3 and basically 3. Representative Davids.
Well, I don't think Representative Murphy and I are all that far apart. Last year, I would say last year, since we passed the reinsurance bill, for the first time, we've had a broad network plan introduced in Minnesota since 2015. And Representative Murphy, we passed in Senate File 1 surprise billing. You can't do that now, and several states have taken what we have done and are implementing in their states. So that's kind of a that's old news, not fake news. It's old news. And it begs the question, Mr. Chairman and members, why is the private market in such disarray? It's because of Obamacare. It's very simple. It's because of Obamacare. And so the theory was, come in and destroy the private market, then you can have government take care of everything because they are so smart and know everything on how to help people, which is obviously not true. In Fillmore County, where I live, we have no all-access plans available because of Obamacare. It doesn't exist. If you have a Blue Cross Plus plan, or that's basically the only one that's there, you can't go to Olmsted Medical Group, which is where you go as a rule if you live in Fillmore County. So several of the points that my good friend Representative Murphy made surprise billing, that's history. You can't do that. And so I would stand for any further questions.
Representative Murphy.
Yeah, thanks, Mr. Chair. And Representative Davids, you and I, we can go back and we can have a further conversation about this. But surprise billing is not gone away in Minnesota. I know another woman who I met this summer. I've known her for years. She had brain tumor. And there was a surgeon that was invited to consult during the surgery. She was asleep. She didn't consent, and got a $30,000 bill. That was this year. A $30,000 bill that she didn't anticipate, a surprise bill because it was out of network. We haven't fixed the problem here yet in Minnesota. We haven't. So, I am glad that there was an attempt. I'm glad it was in Senate File 1. I am grateful that you don't think we're that far apart. I am really concerned about the health of the people of Minnesota. And we'll just close by saying this. You and I did really good work together on the Health Insurance Transparency Act. which was creating competition using a public offering. And I think there's a real important lesson for us in that. And, you know, for whatever reason, this gulf between us, not you and me, but between Democrats and Republicans on health care, we've got to find our way to close that, because the ideological debate that we're having is really leaving Minnesotans behind. And I don't mean that as something directed to you, but really to the body of us.
And Mr. Chairman, to that point, Representative Murphy, if you have that type of situation, I'd like to work with you on that, because the law says you can't do that. And do we need to pass another bill that says we really mean you can't do it? I hope not, but I hope that we could get together and take care of some of those issues for folks. And I've spent since 1982, 36 years of my life trying to get people health care. And so this bill is not that it's not an issue of getting people off health care. It's an issue of how do we go forward from here and make sure people can get health care.
Thank you, Representative Davids. We will go to Representative Gruenhagen-Liebling. Gruenhagen.
You want Representative Liebling and I to talk at the same time? Point, counterpoint. Chair Davis, I just want to thank you for bringing this bill forward and the work you've done as far as healthcare is concerned. You know, there's a lot I could say about this, a lot I have said about it, but I'll try to narrow it down to just a couple comments. I have an article here from CNBC, which is not a right-leaning news media by any stretch of imagination. It says rural hospital shutdowns force communities to take care of themselves. And basically did a survey from 2010, when Obamacare started, to 2018. And we've had 83 rural hospital closures across the nation. That's the highest rate seen in decades. And that can be directly attributable to the expansion of government-run health care, which I belong to a committee of doctors and doctors practicing and retired, and they get about 27% on average reimbursement of their cost on Medicaid and Minnesota Care. So if you want to continue to bankrupt hospitals and medical providers, expand government health care. So when you look at the problems we're having, whether it's narrow networks or some of the other problems we've talked, one of the good places to look for those of you who support Obamacare and MNsure is to look in the mirror, and you'll find the people supporting what the problem is. We're going to cripple our health care system in this state if we don't change this. So, you know, the individual markets, and I've sold health insurance since 1978, has gone from 300,000 in the last several years to down under 160,000. Okay, and doctors and hospitals, once the deductible is satisfied, actually make money on private health insurance reimbursement. They lose money on government reimbursement, and yet that's what we want to expand. So as far as the other comments and Representative Davids, I can only say amen and amen, and we should vote to pass this bill and then sing God Bless America, okay?
God bless America.
Representative Liebling.
Well, thank you, Mr. Chair, and I didn't know that Representative Gruenhagen and I were now related. I guess we have a hyphenated name. So I don't think we knew that.
Usually, if you respond, then I'm going immediately to Representative Gruenhagen, who usually has a question, and vice versa. So we kind of just put them
Well,
together.
Mr. Chair, it was an accident this time because I had raised my hand, so
Yep.
I didn't really want to respond. But since you gave me the opportunity. Yeah, I just want to say that I think the facts might be a little bit wrong for what was just said, because I think where hospitals have closed was in the non-expansion states. If you recall, the Supreme Court took the original legislation, made a big hole in it, and made it optional for states to expand their Medicaid populations. And it's the states, I do believe, where they did not choose to expand Medicaid that have had a lot of stability problems with their hospitals. I mean, maybe there will be somebody in the room here who can speak to this, but I think our healthcare industry as a whole has done very well under the Affordable Care Act, otherwise known as Obamacare. However, I'm not sure that all the patients have. But, you know, I wanted to just, the question I actually raised my hand to address is this, and I don't know if maybe this is more for staff. And so talking about insurance risk, and I know since we're not in the Commerce Committee here, I hope they can answer, or maybe Representative Davids can answer, but we do a lot of our public health care with fee-for-service. So a lot of our medical assistance patients get fee-for-service, and I think even some of our Minnesota Care patients get fee-for-service. So who's bearing the insurance risk for those patients? Isn't it the state bearing the insurance risk for those patients? Can somebody answer that question? Is there some staff in the room that could answer that question?
Representative Liebling, if Representative Davids wants to answer that, I think he probably could take a shot at it. Representative Davids.
Well, thank you, Mr. Chairman. To Representative Liebling, I believe that at this point the state is at risk on those. And what this bill does is it limits state risk, taxpayer risk, to expand this even broader. Because if basically the department ends up paying these bills.
So,
Representative
Mr.
Liebling.
Chair, so thank you. So my assumption is that you're correct, Representative Davids, that the state is bearing risk. And so this is something that I frankly I'm a bit puzzled by. We do a lot of things. The state is an enormous organization. The state has taxing power. Very much like, we have these forecast programs, and there is risk there because if suddenly lots of people qualify for our public programs, they go on those programs, and we have to pay. And so we are, in a very real sense, bearing risk. And we've done that as long as those programs have been around. And frankly, I don't understand why the state has to get a pool of money specially together at all, because I think that the state is very well equipped to bear the risk of bringing more patients on, and in fact that is one of the savings. The larger the pool you have, the more stable your insurance, the more you can estimate what your costs are going to be, and the better off you are. And so I frankly don't find a problem with the state bearing insurance risk, because I think it's something we already do. Whenever we pass a bonding bill, and I think the reason in the Constitution that we have the supermajority requirement is because the state is guaranteeing those loans. This is something the state does. So anyway, I just wanted to make that comment, and then I have a couple of other comments just generally about this. I think somebody asked, maybe it was Representative Gruenhagen, maybe it was Chair Davids, why is the insurance market in disarray? And that it's because of Obamacare. Maybe it was you, Chair Davids, who said that. And I've heard that quite a bit. You know what? And, I think that's completely baloney. I know we differ on that, but I would say that's baloney. Remember what we had in the insurance market before the Affordable Care Act? Insurance companies could and did pick and choose their customers. If you had a pre-existing condition, you could not buy insurance through a private insurance company because they weren't going to take a chance on you. And so, yeah, it worked really well for people who were healthy, and were able to get in, and then didn't develop some big, hugely expensive condition because you would reach your cap, and then you'd get kicked off your insurance, or the insurance company would spend a lot of time working on denying people care, or you'd buy your insurance, and then you'd find out that you weren't covered for this particular condition that you developed. So this was, let's think about what we had before the Affordable Care Act. We had a situation that did not work very well for many, many, many consumers. It worked real well for a few and very poorly for a lot. And so, the Affordable Care Act came in to try to make the insurance system rational, to make it work a little bit better. And did it really succeed at that? Well, no. We might disagree on the fine points, but, in some respects it has. In some respects it worked very, very well. But it's still a system of, at the end of the day, the private insurance system is still a private insurance system, and the more you cut these insurance pools smaller and smaller, the harder it is to predict costs. So, you know, once again, the way I see this bill, Representative Davids, I mean, I know you're not going to. I know you're not going to make the statement that you and I are close together on this, because I think we're about on the opposite poles as we could be on the where we ought to be going. But, you know, I think that it's been kind of the Republican majority has been, or even when you weren't in the majority, it's been the talking point nationally and here in Minnesota that Obamacare doesn't work, and you've been telling us MNsure is dead ever since it was born. And trying to kill it ever since it was born. And, you know, I view MNsure as something that's necessary if we're going to have a system of private insurance, because it allows people to actually shop for it and compare. And does it have its flaws? Certainly it does. But I don't see that the Republicans have any kind of solution. If we agree, and I think we do, that we want people to have health care. We all want people to have health care, to get health care they need, when they need it, where they need it, and without going broke. I think we can all agree on that. And yet, what have we seen Republicans do? You spend $800 million, if you count the money we lost in the federal waiver process, $800 million subsidizing insurance companies. And yet you yourself just said, Representative Davids, that people are still having to buy incredibly expensive policies with really high deductibles. So the problem, that $800 million, maybe it'll get to work a little better, I don't know, but it certainly isn't going to solve the problem. It certainly hasn't solved the problem. So what are we going to do to actually solve the problem? What this bill does is just goes after MNsure. It's just another, let's kill MNsure, let's kill MNsure. That's another talking point that's been used over and over and over. And, you know, I could join with you in killing MNsure if there was a real solution that would get people health care they need. But boy, I haven't seen it. I just haven't seen it. So I just think this bill, I just see it as another attempt to undermine what we have and to stop the state from moving forward to actually try to give people a better option. And I just think it's, you know, more of the same. And, you know, it just, here we go. It's just another way of saying no, 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 no. And let's see a real solution, something that we can be for, not just killing MNsure.
Representative Davids.
Thank you, Mr. Chairman and members. First of all, to the Pinto question, the full federal exchange is 3.5, but the state-based exchange on the federal platform is 2%. Is what it was last year. So just clear that up. First of all, this bill does not impact current Minnesota Care or MA. So let's just get that one figured out. But Representative Liebeling and I are a little ways apart on some issues here. I'll admit that. But to say that before Obamacare destroyed the individual market because it created something you learn in Insurance 101. You can't have adverse selection. And Obamacare is adverse selection. So you're putting unhealthy people on a group and you're raising the price for everybody. And people get off that group because they can't afford it, and down she goes. That's where we're at now. That's just the fact. But to say it was worse before, that is my good friend Representative Liebeling with some very revisionist history, because what we had before was much, much better. Lower rates, people were covered. If you couldn't get coverage, there's a thing called the Minnesota Comprehensive Health Act of 1976 that we put people on. And so you could keep the groups healthy and cheaper because you had the high-risk pool over here called MNsure. So it was so much better before. It's not even comparable. Back in the day, you could have, as an insurance agent, you could have 20 companies you could offer, and you'd shop the rates and get the lowest rate. It's called competition. It worked pretty good. But Obamacare destroyed that. So to say that it was worse before is just nonsensical at best, because it was so much better before. I never had anyone that I wasn't able to get coverage for. Nobody in the previous system was denied care or coverage. Now I have people in situations that cannot buy coverage. They cannot get coverage. If they need coverage, they come in, they say, it's July, I need coverage. I can't get it for you because of Obamacare. That is worse than it was before, because if you came in before Obamacare in July and wanted coverage, I got it for you that day. So we shouldn't really speak of what we do not know. And before was so much better, from rates to access, and so to say that it was worse before is just simply not true.
Representative Schultz.
Thank you, Mr. Chair. I've been probably taught by the best health economists in the country, the University of Minnesota, and feel like I need to address a few things that Chair Davids has talked about. The market before the Affordable Care Act was not working. There was market failure. And that is the reason why the government stepped in to try to correct that market failure. So we had adverse selection based on health risk, where people who were sick could not get coverage because of pre-existing conditions. And if they had pre-existing conditions, they were charged a lot more. The high-risk pool was not affordable for most people with chronic conditions. And so separating them out created a position where that pool kept getting more expensive, and then marginally healthy people left that pool, and that created a death spiral. So I think that it was worse before the Affordable Care Act, and today, when the federal government tried to repeal the Affordable Care Act, people finally understood that Obamacare is the Affordable Care Act, and they wanted to keep their health insurance that was affordable and not lose it. And you see that it's becoming more and more popular every day. So I don't think the political message harking on killing the Affordable Care Act is going to be popular anymore, because people finally realize what it is. I think the 4 years that I've been here, or the almost 4 years I've been here, I've really heard a lot about critiquing and criticism of healthcare reform. And the solutions that I put on the table by Chair Davids and other Republicans is to sell what I call junk insurance, insurance that doesn't cover necessary services like chemotherapy, that would have high deductibles. You could say there's more policies on the market, but people won't be able to afford them, and things wouldn't get covered. And to Representative Gruenhagen's point, when things are not covered, it's the providers that pay, and they'll see a lot of uncompensated care and bad debt. The other solution was to allow for-profit health insurance companies to operate in the state, and I haven't seen, that hasn't had much of an effect yet of for-profit companies operating in Minnesota in terms of addressing affordability. And we've had even more problems with narrow networks in our state that we haven't addressed. And the other solution was to have reinsurance and to pay $543 million to private health insurance companies to offer individual policies. That is not sustainable. We cannot keep subsidizing private health insurance companies. And the attack on MNsure, it's just a platform where we're selling private health insurance products. And so it's maybe we should be criticizing those private health insurance companies and their excess revenues and their reserves, rather than criticizing MNsure. Recently, the state of Nevada was on the federal exchange and could no longer afford the 3.5%, and so now they're thinking about creating a state-based exchange. And I think that we, as state legislators of Minnesota, need to come up with healthcare reform and not rely on the federal government. And we need to act fairly quickly and come up with bipartisan solutions and lead on health insurance and healthcare reform so people can afford healthcare. But I think the solutions I've seen will not work going forward, and I haven't heard a bipartisan solution that I think will work. And all I've seen from the federal government are policies to further destabilize the individual market, and we can't continue to subsidize private insurance companies. At least with government programs like the Minnesota Care Buy-In program, people are paying their own way. Yes, reimbursements are not at the fee-for-service level. They could be at the Medicare reimbursement level. But you have to show me where providers' costs are before I can tell you whether or not that reimbursement is not adequate. And we haven't addressed the cost side of this equation in healthcare. And if we're not serious about addressing healthcare costs, we're going to have this dilemma every year.
Thank you, Representative
Chairman.
Schultz. Representative Davids.
Thank you, Mr. Chairman. Well, here we go again. Representative Schultz, people could get coverage before Obamacare. In fact, there was 260,000 people in the marketplace back then. Now there's, what, 160 or less? Back when Obamacare was coming online, people would say, well, people can't get coverage. And I'd say, who? Who can't get coverage? I said, find me one person that couldn't get coverage. Find me one. They couldn't do it because it didn't exist. You kind of make my point, Representative Schultz. I see I've got some support for this bill from you because you said Nevada couldn't afford 3.5%. That's my point exactly. Neither can Minnesota. We can save $30 million on this bill for our insureds. And MNsure was not this big unaffordable thing. A lot of times MNsure was cheaper than Blue Cross Blue Shield or other carriers. The MNsure law said you could not go above 1.25% of the average cost in the state. And many times they were cheaper than other ones. In fact, I had people with Blue Cross after taking a big rate increase, they'd say, can we get on MNsure? And I said, well, you got to be like kind of sick or something, you know? And they say, well, I don't feel good. And I say, no, you got to have a note from your mother. So as far as junk insurance, I'm not sure what that comment was. I'm not sure. We don't sell junk insurance that I'm aware of. You know, so we have spent over $550 million on MNsure for something that for the last 100 years before Obamacare, insurance agents did at no cost to the state whatsoever. Amazing.
Thank you, Representative. We're going to go to Commissioner Johnson. I apologize, Commissioner Johnson. I thought you had signed up for a different bill, and so I neglected to go to you before member questions, so I do apologize. We are at 55 minutes, and we're going to vote at 2 o'clock. So, Commissioner Johnson.
Thank you, Mr. Chair. I appreciate the opportunity to be here. I'm here to speak to the Minnesota Care buy-in proposal and to oppose this bill, which would prohibit Minnesota from implementing Governor Dayton's proposed Minnesota Care buy-in. It's been discussed at quite some length over the last 55 minutes. I would just highlight a few points. The uninsurance rate, as has been discussed, has gone up by 2 percentage points over the last couple of years, and that certainly concerns us looking at what's happening across the market. That's 116,000 more Minnesotans who are without insurance today versus what we had in 2015. And that's worse in rural areas and worse for people of color and American Indians. And as we look at that and look forward, we need to have a plan for what we're going to do with the individual market. We're looking at reinsurance again for this year and for 2019, but in 2020, the reinsurance runs out. And what Governor Dayton is proposing, again, proposed it last year, but this year to implement in 2020 a Minnesota Care buy-in proposal. This proposal would build on our Minnesota Care program, which has been successful in Minnesota, offering affordable care to low-income Minnesotans for 25 years. We project that about 100,000 people would use the Minnesota Care buy-in proposal. They'd be able to buy in. Their premiums cover the cost of care. And it will provide the access to the full Minnesota Care benefit set. You'll remember Minnesota Care formerly did cover people above 200% of poverty. So in a sense, this isn't new. It's going back to methods that we had used prior to the Affordable Care Act as well. Some of the conversation here was around the rates that are paid to providers. This proposal would use Medicare rates, not Medicaid rates, for payment to providers. That's part of the reason why the premiums under this year's Minnesota Care buy-in are higher than the premiums we looked at last year. But the other reason those premiums are higher than we looked at last year is because when we worked with the Department of Commerce, we're expecting the premiums in the individual market to be very high in 2020. I mean, that's what the actuaries are projecting at this point. The $659 that we're projecting per person under Minnesota Care would be 28% lower than what we project we'd see in the private market for the private insurers. And so that's a significant reduction, would make health care much more affordable to many Minnesotans in this market. And I'm not here to say that this is a perfect solution because I don't think we have a perfect solution. And I think there's been a lot of discussion around here about that over the last hour or so. What it is an idea and a solution that we think would solve a lot of the problems that we're seeing in the individual market. And it's easy to criticize other solutions, but it's harder to put one on the table that you think will work going forward, and that's what we're attempting to do here. And I appreciate the committee's time.
All right. Representative Liebling.
Thank you, Mr. Chair. And I just wonder if Mr. Johnson could try to answer my question about insurance risk, because I was kind of puzzled that the department is putting together a pool, because I thought the insurance risk would be carried by the state. Like, isn't that what we do with forecast programs?
Commissioner Johnson.
Madam Chair and Representative Liebling, that's correct. Fee-for-service, essentially, the state is bearing the risk. That's what the forecast is, and we bear the risk for that part of our programs. In the managed care contracts, essentially, we transfer that risk to the managed care organizations. Under this proposal, we're going to work with managed care organizations, and we're going to offer them contracts that will be like the ones we operate under our PMAP or Minnesota Care, meaning it would be our goal to try to transfer the risk to them as well. How those contracts work out, we're not sure. This reserve pool is both to help us in case we need it for actual reserves because we overspend, but it's also for cash flow purposes. And so that's part of the reason why we put a reserve pool in and to back up this proposal, and because we want it to be wholly separate from what we do in our other managed care contracts and what we do in fee-for-service.
Thank you.
All right. Further questions? Seeing none. Representative Davids, final word.
Well, thank you very much, members. This is an important step forward to make this whole thing work. And I'll be talking offline to Mr. Johnson to see if they found any of that $30 million that they can't find in Minnesota care premiums. That's another issue for another day. So that, Mr. Chairman, members, I'd appreciate your vote to get this over at the tax committee. We'll get an extremely fair hearing.
Thank you, Mr. Chair. I will renew my motion that House File 3543 be re-referred to the Committee on Taxes. All those in favor, please say aye. Aye. Those opposed, no. No. Motion prevails. 3543 is re-referred. Thank you, Chairman Davis.
Thank you, Mr. Chairman and members of the committee.
All right. Next up, we will have Representative Haley, House File 3240. Representative Haley? It was, yeah. Representative Haley moves that House File 3240 be re-referred to the General Register. We have the bill before us. Representative Haley has an oral amendment. She moves that on line 8.1, reinstate the stricken 14, and on line 8.2, delete 8. Is that your technical amendment, Representative Haley?
Thank you, Mr. Chair. Yes.
All right. All those in favor of the Haley technical amendment, please say aye. Aye. Those opposed, no. Haley oral amendment is adopted. Representative Haley to 3240 as amended.
Thank you, Mr. Chair and committee members. House File 3240 modifies the licensure requirements of home health care agencies in Minnesota. This bill was brought to me by the Minnesota Home Care Association on behalf of a coalition of providers and others with expertise on these issues, including Leading Age Minnesota and Care Providers of Minnesota. Over the years, individuals involved with home care licensing have identified areas in the statute that were sometimes unclear, unworkable, or outdated. This is causing questions about what was expected for compliance and if the law could be applied consistently now and in the future. I'm going to let Mr. Kevin Goodnow walk you through details on the bill, but know that this bill is the result of over 5 months of effort working between the Minnesota Department of Health and all the various stakeholders to clarify this ambiguity and provide consistency in the statutes.
Welcome back to the committee. Mr. Goodnow, please introduce yourself for the record and proceed.
Thank you, Mr. Chair, members of the committee. Kevin Goodnow. I'm here on behalf of the Minnesota Home Care Association. And I could go through the details of the bill, but I believe the bill's in here to just talk about the fiscal note that you've requested. And I just want to note on line 5.15 and 5.16 relates to a fee that's included in the bill. The fiscal note came back and said that there was no there's no reliable way to estimate how many providers would fall under the notification requirements that would trigger the fee. And so they put a zero fiscal note on this bill and no appropriation to it as well.
All right. Thank you. Mr. Goodnow, are there questions? All right. Seeing no questions, Representative Haley renews her motion that House File 3240 be re-referred to the General Register. All those in favor, as amended, all those in favor, please say aye. Aye. Those opposed, no. Motion prevails. 3240 is re-referred. Thank you.
Thank you.
Representative Franson, are you ready to do House File 4094?
Okay.
Representative Franson moves House File 4094 be re-referred to the General Register. Representative Franson has an A1 amendment, and she will present the A1 amendment.
Well, I thought I had my notes.
All right, thank you, Representative Franson.
Thank you, Mr. Chair. And for the amendment, it kind of clarifies some concerns that Representative Liebling had at our next stop, and I'd ask the department to come up and run through that.
All right. Is somebody from the department able to come down? Welcome to the committee. Please introduce yourself and proceed.
Good afternoon. My name is Cindy Yang, Director of Child Care Services Division at the Department of Human Services.
And can you address the A1 amendment?
Mr. Chair, thank you.
Please proceed.
So the A1 amendment, after consulting, we currently, as is currently written, anyone who claims that their trainer could create a certificate for themselves and claim they offered a training. The A1 amendment fixes these changes, would limit those, and could take advantage of this new option to only those who are trainers.
Nick, if you could please just get a little closer to the microphone so that we can hear you. Thank you.
Sorry about that. Can you hear me?
There you go. Thank you.
These changes would limit those who could take advantage of this new option to only those who are trainers approved through the Minnesota Center for Professional Development, and only when they offer approved training. The other concerns as written is that it limits the types of training that a trainer could get credit for to only ongoing in-service requirements. We believe that the intent was to allow it for all ongoing training requirements for family child care providers, such as SIDS or training and other types of ongoing training. The amendment would suggest change would allow trainers for all of the types of ongoing training requirements for licensed family child care providers to count it towards their own ongoing training requirements. The other concern is that limiting it to just a half hour of training offered rather than all of the hours is unnecessary. Other professions allow all of the hours trainers offer to count for their own continuing education. So this amendment will also allow all of the hours of training offered to count, not just a half hour.
Thank you. Are there questions on the A1 amendment? Representative Pinto.
It's not on the amendment.
Okay, to the amendment. All right, seeing none, all those in favor of adoption of the A1 amendment, please say aye. Aye. Those opposed, no. The A1 amendment is adopted. Representative Pinto.
Thank you, Mr. Chair. And I guess I'm curious about, this seems great to me, the bill does, but I just, as long as it's up, just want to find out, what is the mechanism for approval of the training requirements in the first place? I understand what the bill does is has it be that after the amendment that an approved trainer through the Minnesota Center for Professional Development can get credit. That makes sense to me. Does that same sort of screening mechanism apply for the training in the first place in the rest of Subdivision 7? And I'm not sure if my question is making sense, but like what's the criteria for getting training approved for a child care provider in the first place? I just get that sense.
To the testifier or Representative Franson.
Mr. Chair, members of the committee, So under Minnesota Statute 2458.5, under family child care training requirements, we do have a statute that specifically calls out the specific training requirements that this provision will also follow.
Mr. Chair, I guess in looking at the at that subdivision, I see the content, but is there somebody that sort of reviews? I guess I'm comparing the experience as a lawyer, that there's, you know, somebody has to kind of approve the content and say, yep, this is quality content for which somebody should get credit. I'm just wondering, is there something similar in the childcare space?
Mr. Chair, members of the committee, DHS does have a data system that the providers who are certified to provide training and going through the certification will follow those same requirements as part of the data system that is listed as part of this amendment. Yes.
Okay, I think I'm all set. Thank you, Mr. Chair. Thank you, and thank you, Representative Franson.
Further questions? Representative Liebling.
Thank you, Mr. Chair, and thank you, Representative Franson. I think that it's good to see that you tried to address some of the issue that I had on. I just want to clear up one thing that's I'm a little bit confused about, and that is, I think this is much better. But the question is, if you're, say you're teaching, well, let me back up. I assume that the training that the providers are required to have cover different topics, right? And so if you're a person who's doing, say, training on sudden infant death syndrome, and you teach that course over and over and over, do you then get exempted from the rest of the training you would otherwise have to have under the bill?
Representative Franson.
No, Mr. Chair, Representative Liebling, no, you would not.
Okay, and Mr. Chair?
Representative Liebling.
Thank you. So good. So it seems like what this is doing is just allowing somebody who takes the time to be a trainer to not have to go and take that course in order to get credit. So they get credit for the fact that they are preparing it and teaching it and sort of, you know, that getting that exemption based on that expertise and the time they spend doing that. Am I right in how I'm understanding that?
Representative Franson.
Mr. Chair, Representative Liebling, yes. What the department did is they listened to you intently, as well as the rest of us, and they took note of your questions and then came back with the amendment to address those concerns, and everybody agreed that they thought where you were coming from was well within reason, and here we are today.
Okay, thank you, Mr. Chair.
Representative Liebling.
Thank you, Representative Franson. I'm just, you know, just because it's a little confusing, I'm trying to kind of put the amendment in here and make sure. And is that what the testifier understands too, that's what this does now, is it just gives those trainers credit for teaching that they don't have to go and take a course in something that they are a trainer in? Is that kind of what this is essentially doing?
Mr. Chair, members of the committee, yes, under the training requirements that are authorized under the statute, yes, they would be allowed the number of hours that are required under those statutes if they are teaching those courses, yes.
Okay. Thank you, Mr. Chair.
All right. Mr. Berg, it's my understanding that there's no fiscal note or cost implication. Could you just clarify that and put it on record for me, please?
Mr. Chair, that's right. There's not a fiscal note request. The department, I believe, indicated in the reform committee that they're okay with this idea, and they subsequently, the department has communicated to us that they would not put a cost on this bill.
All right. Then, in that case, Representative Franson re-renews her motion that House File 4094 be re-referred, as amended, be re-referred to the General Register. All those in favor, please say aye. Aye. Those opposed, no. Thank you, Representative Franson. And that is re-referred to the General Register. Representative Peterson? Welcome to the committee, Representative Peterson. I will move that House File 3571 be re-referred to the General Register, and I understand that you do have an amendment, the A2 amendment, and I will move the A2 amendment to put that before us. Thank you, Representative Peterson. Welcome to the committee, and please proceed.
Thank you, Mr. Chair and members. This is the Baxter Healthcare legislation, and House File 3571 amends the Pharmacy Practice Act to exempt manufacturers of home dialysis drugs, supplies, and devices from the requirements of the Act if the facility maintains control of all products from the manufacturing process to the delivery to the patient. This bill was introduced on behalf of Baxter Healthcare and would affect its facility in Champlin, Minnesota. This bill would mirror current practices that have been passed in 12 states. And things to remember is this product arrives and leaves in manufactured sealed packaging upon delivery by the manufacturer. It does not include diabetes supplies or any other type of device, DME, or pharmaceutical product. As well as all products and devices must have FDA approval. So the product and devices must be delivered directly to the patient or his or her designee for self-administration or to a healthcare provider or institution for administration of dialysis therapy to a patient. And to my knowledge, this is not opposed by anyone and there is no fiscal impact. And then in regards to the A2 amendment, current law requires pharmacists to be on duty within a licensed pharmacy when dispensing drugs. And this amendment language would allow pharmacists who provide services for nursing homes to remotely and securely access their pharmacy prescription processing computers to complete data entry of prescriptions. So in essence, the pharmacist is just as smart and qualified in their home after hours as they are in the four walls of the pharmacy, and so that people can get their medications. And it will definitely help accommodate those emergencies. And that is the substance of the bill, Mr. Chair.
Thank you. And are there questions on the A2 amendment portion of the bill, just to the A2? Seeing none, let's amend that. All those in favor of adoption of the A2 amendment, please say aye. Aye. Those opposed, no. The A2 amendment is adopted. Now we are on to 3571 as amended with the A2 amendment. Questions for Representative Peterson? Representative Liebling.
Thank you, Mr. Chair, and I'm sorry if I missed this, Representative Peterson, but the Board of Pharmacy supports this?
Representative Peterson.
Thank you, Mr. Chair, and Representative Liebling. That's yes.
Okay, thank you.
Further questions? Representative Murphy.
Thank you, Mr. Chair. And Representative Peterson, are there other examples where a pharmacist is doing the work that you're describing remotely and away from the pharmacy, so approving a prescription from home? Are there examples of that already in place? And, I'm just asking to make sure that I understand, if we're going to move in this direction, about the security of that and the validity of that.
Representative Peterson.
Thank you, Mr. Chair and Representative Murphy. Basically, the Board of Pharmacy has established the language so that the protocols are in place. And so that has been working. Actually, it's been worked on for the last 2 years. And that is why it's being brought forth. Because in essence, in practice, pharmacists were doing this before. And then they thought, we're really not sure if this is actually abiding by the law. And that's where it's more clarifying language on what is appropriate.
Further questions? All right. Final word, Representative Peterson.
Thank you for your support.
All right. Representative, I will renew my motion that House File 3571 as amended be re-referred to the General Register. All those in favor, please say aye. Aye. Those opposed, no. 3571 as amended is re-referred. Thank you, Representative Peterson and Mr. Hanson. All right, next up we will have House File 2962. All right, Representative Peterson, we are going to lay this bill over, but we will bring it up before us, and you want to speak to amendments to the bill, and I'm not sure in which order you would like to do that. So if you could, please direct me which one.
Thank you, Mr. Chair. I will, how about if I just sort of explain it like I explained the last bill, and then we can address the amendments as they come up? Does that sound good, or
Sounds
would
good.
you
Why don't
prefer the
give
other
a
way?
general background if you want to start out that way, that'd
Sure.
be great.
Many of you serve on HHS reform, where we heard Dr. Brian Sick testify in support of House File 2962, and also other physicians and nurse practitioners have also urged their support of passing this legislation because it will expand access to life-saving medications and treatments that pharmacists are equally or sometimes more qualified to deliver. Pharmacists can prescribe opioid antagonists for the treatment of overdose, clarifying overdose like naloxone, and also FDA-approved smoking cessation medications, excluding bupropion, and only FDA-approved, as well as travel medications recommended by the CDC specifically for patients and residents traveling abroad. This will all be under the protocols established by the Board of Pharmacy, and will also follow the criteria necessary. So the difference between these three areas is that none of them require a diagnosis by a pharmacist. Basically, if you want to quit smoking, you make that decision. If you want to go travel and you're going to a country where you might need to get some immunizations or antibiotics, those are specifically laid out in a website that you can access through the CDC, as well as if you're overdosing, you would probably like some help. Allowing pharmacists to complete patient medication and consultations and counseling in conjunction with the purchase and dispensing of these medications will reduce overall costs to the state and private insurers. Ultimately, House File 2962 will save lives and ensure greater access to healthcare professionals across Minnesota. Minnesota Department of Health reported that 53 of 87 counties are underserved in this area. And also CMS has called for pharmacists to expand their role. In regards to the H6 amendment, DHS has suggested clarifying language around the travel medications and insurance coverages, and it references Minnesota statute that pays pharmacists for services through medication therapy management provisions. Both the private insurers and the DHS have told us they do not oppose these provisions. And so I guess maybe we should start with the A6 amendment from that standpoint, Mr. Chair.
All right, Representative Peterson, I will move the A6 amendment to the A6 amendment.
Thank you. And then on the A4 amendment, this is a recommendation also from the Board of Pharmacy, and it's for emergency veterinary compounding. The Board of Pharmacy issued a guidance to allow pharmacies to compound drugs for veterinary use when those drugs are needed for emergencies or other urgent situations, and animals would suffer or die without access to these drugs. These recommendations and guidance was based on a similar guidance issued by the FDA. So this amendment would allow pharmacists with the flexibility to help vets treat animals on a moment's notice. No one opposes and quite frankly helps save animals' lives on the A6 amendment.
All right.
Or A4 amendment, excuse me.
All right. Let's go ahead and put the A4 amendment on. If we do have any questions, Representative Liebling to the A4.
Thank you, Mr. Chair, and I don't have any problems with the amendment as such. I'm just wondering, though, we don't usually do veterinary things in Health and Human Services, and I'm just wondering whether this should be, if this goes on, whether this should be seen in some other committee, like probably Ag? I don't even know who it would be that has jurisdiction over this.
I see Mr. Weiberg back there. Perhaps Mr. Weiberg could come down and...
Thank you, Mr. Chair. This is for prescribing in a veterinary compounding pharmacy. So,
welcome to the committee. Mr. Weiberg, please introduce yourself and proceed.
Mr. Chair, members of the committee, yes, sometimes I kind of make body motions back there you might pick up on. No, actually, this deals with compounding medications. In fact, the Board of Pharmacy is authorized by the legislature to regulate all compounding, whether it's done for human drugs or animal drugs. And we even regulate dispensing when it's done by practitioners, including veterinarians. So no, this is definitely under the board's jurisdiction in this particular area. There are certain things involving food-producing animals that are probably more under the agricultural department. But even in that case, when it comes to compounding for food-producing animals, we still regulate that.
Thank you.
All right. Thank you. All those in favor of adoption of the A4 amendment, please say aye.
Aye.
Those opposed, no. The A4 amendment is adopted. And to the A6, questions on the A6 amendment? Seeing Representative Liebling.
Thank you, Mr. Chair. And so Representative Peterson, it was just a little bit confusing before, and we were kind of talking about all these things at the same time. So could you just describe again what the A6 is doing? If you wouldn't mind, because I think I didn't quite catch what changes are being made here.
Representative Peterson to the A6 amendment.
Thank you, Mr. Chair and Representative Liebling. Basically, DHS reached out to us and they felt that they wanted to clarify the language around what the travel medications were, as well as how that insurance would be handled. So that is directly from the department to make that clear in statute.
Representative Liebling.
Okay, well, Mr. Chair, thanks. No wonder I didn't understand what you said, because you didn't, yeah, maybe somebody who actually wrote or helped write the amendment could come down and actually explain to us what it does.
Welcome to the committee, Mr. Hope. Please introduce yourself and address Representative Liebling's questions regarding the A6 amendment.
Good afternoon. My name is Chad Hope. I'm Deputy Director for the Division of Purchasing and Service Delivery at DHS. Mr. Chair, Representative, the language before you, we were engaged for some technical assistance. The first piece was identifying what medications are in scope as far as travel medications. The initial language referenced the CDC website, but it was pretty broad and could change at any time. So we had recommended that they work with the Board of Pharmacy to, excuse me, not only list the reference to the CDC website, but identify the medications that are in scope. The punctuation was really to clear up some numbering where bupropion was being excluded from inclusion and then not trying to exclude the additional drugs. So it was really to get the intent. And, oh, excuse me. The last piece was we were engaged about whether or not we could reimburse for medication therapy management if a pharmacist was to prescribe under this expanded scope. And as written, it had not addressed any sort of covered service. So we had recommended that they look at 256B if they wanted to expand to medication therapy management.
Representative Liebling.
Thank you, Mr. Chair, and so thank you for that explanation. And so the fiscal note, does that include the expanded services that would be, or that could be billed under the amendment?
Direct that to Mr. Hope or Mr. Berg. Mr. Hope.
Mr. Chair and Representative, the fiscal note did not build in an expanded benefit set as if it were provided through medication therapy management, which is currently a covered service today, this would be kind of a new component within that existing service. You could also make a case that perhaps it would offset an office visit that did not occur. So when we looked at it in the entire scope, we could not identify a utilization change. These medications are also currently covered, so there really wasn't a change for the access from a claims perspective. What we did have in the fiscal note is systems changes because we would need to allow for a claims processing edit so that pharmacists could prescribe, and that's not currently allowed today. Those claims would deny.
Okay, thank you, Mr. Chair. Thank you very much.
All right, further questions? All right, thank you, Mr. Hope, for the clarification. Appreciate that. And we did pick up a small fiscal note, which we did not anticipate, so that's why we will be laying House File 2962 as amended. We will be laying over. I'm sorry, Representative Murphy.
Mr. Chair, and I have just a comment to the bill.
Okay.
Is that okay?
Yep. Mr. Lindu, did you care to testify to the bill?
I will identify myself, Mr. Chair, thank you. Jeff Lindu, I am a pharmacist, practiced for 42 years with Thrifty White Pharmacy, a Minnesota-based employee-owned pharmacy. Retired just about 2 years. I'm a past president of the Minnesota Pharmacists Association, chair of the Government Public Affairs Committee of MPHA, which is what places me here. I think Representative Peterson did a good job in describing the bill, so I will just be available for questions.
Thank you, Mr. Lindu, for making the trip here today and for being available for member questions. Representative Murphy.
Thank you, Mr. Chair. And this is more a comment, I think, for Representative Peterson, or maybe just for the members of the committee when I think about this legislation and listening to the rationale about billing and capturing reimbursement. And in my experience, in my practice, different providers do different parts of this chain of work. And it's in part a check and balance on the work that we do, right? So there are prescribers, there are dispensers, there are administrators of medications. Different providers do those things. It's parts of our scope of practice. And sometimes we think about scope of practice as turf, but it really is in many cases tied to expertise and a little bit of check and balance on the various providers. So as I think about this with these three different treatments, if you will, it seems to me that there's a combination of those three things altogether: prescription, dispensing, and in some cases the pharmacist being able to administer. And this is not, for me, a complaint about pharmacists and scope, but I think a caution for us to think about sort of the inherent responsibilities of providers in terms of diagnosis and assessment, and those roles being articulated clearly when we think about how we're building the system in the future. And in this isolated incident around these three treatments, it makes sense about what we're talking about. But if we were to take and expand what this model is in this incident to a more broad question, I think that we may be heading in a direction that we don't intend to. And so there's an inherent scope question in here, but also I think a safety question for the provision of care among the variety of licensed providers in their preparation. And I just want to call that out here on the record so that we're thinking about that.
Representative Peterson.
Thank you, Mr. Chair, and Representative Murphy. I think you bring up a valid point, and that's why these particular areas are very, very specific, and there is no diagnosis involved, because clearly we want to keep that relationship with our physician very strong. And on the other hand, as we're looking at healthcare and trying to bend that cost curve, we also have to figure out what is the appropriate place for the physician and what is an appropriate area for pharmacists to be able to provide that access to that care. And so, again, that's why it's so narrow in these particular areas, because you're right, we don't want to start going into some place that we don't feel that they're qualified to go.
All right, thank you. Representative Loeffler.
Well, thank you, Mr. Chair, and Representative Peterson. I'm concerned about the travel medication section and that it's pretty sparse. It just says that it's a medication that's been recommended by the CDC for per individuals traveling outside of the United States, but there's no duty of the pharmacist to check for recent updates. We know that all across the world, outbreaks happen of of all kinds of preventable diseases, and they change regularly because people are flying in airplanes from place to place across the world. And nothing in here says that that pharmacist has to look at an updated site to determine what is really necessary in traveling to a particular country or a particular region of the nation. And I don't think you can assume that your average pharmacist stays up on, you know, the tuberculosis strains that are right now, you know, emerging in Brazil versus something else that's in another part of the globe. And I'm wondering if in developing this, you've had any discussion about fleshing that out just like you have on the tobacco cessation, so that there's more direction and guidance, because we really hate to have Minnesotans trusting that when they go to their local pharmacist that they've done that kind of background, and yet we've never expected them to it in the law.
Representative Peterson.
Thank you, Mr. Chair and Representative Loeffler. That's right, and that's why the Board of Pharmacy will be very involved in establishing the protocols and the procedures to go through, as well as the people who really do keep on top of that type of information is the CDC. And that's why the current practice right now is to go to that website and find out what are the appropriate medications that need to be addressed at that time. Do you want to add anything else? Mr. Chair?
Mr. Chair, Representative Loeffler, I think Representative Peterson is accurate there. The Board of Pharmacy is going to flesh this out with protocol, and I don't see a pharmacist trusting their memory from the last time that they went to the website to look for travel to a particular area. And I would have to believe that even if the protocol doesn't state that specifically, that any pharmacist, a healthcare professional, is going to go to the CDC website at the point of that interaction with the patient to make sure that they're using the most current information. And the language essentially does say that, in saying that the pharmacist must prescribe medications recommended by the CDC, and that language would imply recommended by the CDC at the time of that patient interaction.
All right, thank you, Mr. Chair.
Thank you, Representative. Final comments, Representative Peterson.
Thanks for your support.
All right, House File 2962 as amended is laid over. And next up, we will do Representative Albright's House File 2274, and we will do House File 3062 and 4191 tomorrow. This is a capital investment project, so we will have it before us for information only. Representative Albright to House File 2274. Representative Albright.
Thank you, Mr. Chair and members. House File 2274 is a bill that goes to address some of the gaps in our state's mental health system of care. We've all had examples from our own families and communities that have left us wondering what the state can do to address the myriad of needs for people facing mental health crises. Just one of the many gaps in our system is the lack of appropriate crisis beds for individuals with acute needs. House File 2274 is an attempt to bring all community partners to the table, counties as the mental health authority, nonprofits, hospitals, and providers, to assess the needs in their community, envision what an appropriate crisis facility might look like, and then work together to put together not just the bricks and mortar, but also the sustainable services. I've provided the committee with amendment language that will not be taken up because we are just in an informational hearing here. That is the result of continued work on the bill between the various stakeholders to make it a very workable and productive outcome once this bill is signed into law. With that, Mr. Chair, I have a testifier who would like to speak to the bill as well.
Welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chair and committee members. I'm Jim McDonough, Ramsey County Commissioner. I chair the Ramsey County Board of Commissioners. Ensuring a continuum of care, providing crisis intervention and stabilization services in the community is critical in establishing an effective mental health continuum of care, where communities can begin to assist individuals in their recovery and promote wellness in their community. Too often, individuals with serious mental health end up in our jails, our hospitals, or on the streets homeless. This is the outcome of not planning, building, providing, or maintaining a continuum of care. Our residents who have a mental health condition are left without support, their conditions deteriorate, and they end up in bad and worsening situations. They lose their jobs, their housing, whatever stability they have achieved. Strengthening our mental health system involves careful planning and partnerships in our communities. While this is true in every community, we benefit when each community is allowed to use their resources in ways that work to support their residents. All of our communities are unique. We have strengths, we have different gaps, and as our population, in the populations we serve. The bill honors our unique nature by providing each community the opportunity to build what they need, not a one-size-fits-all, focused in on residents. In Ramsey County, we have an established urgent care center providing services to adults who are at risk or experience a mental health crisis. This center offers a glimpse of what this bill could envision. It provides one example of one community's approach. In 2011, after several years of planning, Ramsey County opened its urgent care center for adult mental health. The partners who built this facility and continue to operate it formed the Mental Health Crisis Alliance, which includes 3 counties, Ramsey, Washington, and Dakota, 4 health plans, Health Partners, Blue Cross, Blue Shield, UCare, and Medica, 3 hospitals, Regents, Health East, and United, 3 advocacy consumer organizations, NAMI Minnesota, Minnesota Recovery Connection, and Mental Health Minnesota, and the State Department of Human Services. These partners put $9 million into constructing the center. We did this at a time when no one else was doing this. Our urgent care center serves residents in Ramsey, Washington, Dakota County, provides 24-hour crisis line referrals to other services, stabilization, and a safe place to gather for individuals and their families. Representative Albright's bill would help other communities build upon partnerships to create centers that work for them and help their residents who are experiencing mental health crises and require stabilization services, wraparound services needed to maintain long-term stability in their lives. In many communities, this may include a short-stay facility with beds where individuals can stay for a few days or several weeks to stabilize. This bill also includes investing in housing, a foundational element for all of us, especially for individuals with serious mental health conditions. I recently served on the governor's mental health task force, and part of that work was aimed at identifying ways to strengthen the mental health system in our state. That process highlighted that there is a lot of good work going on, but that the state is lacking a comprehensive continuum of care that promotes mental health and supports Minnesotans with mental illness to recover in their communities. House File 2274 is a part of strengthening that continuum. Counties have consistently demonstrated the dedication in providing an adequate mental health system for Minnesotans by investing in our communities. Counties see this bonding proposal as a way to continue that momentum with the state's help. So far, we have 79 counties in Minnesota that have supported this. We're sure that within the next 2 weeks, we'll have all 87 counties with resolutions of support for this investment. Mr. Chair, thank you for the opportunity to testify.
Thanks for coming in today.
I'm sorry. I also wanted to point out I do have some folks from Olmsted County are in the audience available if there's questions about what this might look in southeast Minnesota, but I know all parts of this state are looking forward to this.
Thank you. I appreciate that, and I appreciate you coming in to testify, Mr. McDonough. Other questions? Representative Pinto.
Thank you, Mr. Chair. And all I want to do is just acknowledge that Commissioner McDonough has been such a leader in this area, and to thank him for his work, and to thank Representative Albright for bringing this forward. I appreciate it. Thank you, Mr. Chair.
All right. Other questions? Representative Loeffler.
Well, thank you, Mr. Chair. And I mean, the need for this is not in any way questioned. And I'm glad that the counties are working and have worked with a lot of partners to bring this forward. The one question I do have, and it's based on the state's own experience, is we built a series of 16-bed hospitals throughout the state in order to qualify for medical assistance and to serve people close to home. And one of the painful lessons of that was that we have such a shortage of psychiatrists and appropriately trained mental health personnel that just because you build it doesn't mean you can get the workforce you need to make it happen. And I know that one of the criteria is that they're to outline what the staffing requirements are, but I would really like us to consider, fleshing that out to say that they've actually identified strategies to recruit and retain that personnel, because we really do need to find some creative ways to get personnel to go to other parts of Minnesota and provide those kind of support services, or to provide telemedicine, or in the initial design of the facility, or whatever's needed to make sure that they have access to the kind of professional care they need. And like I say, that might be telemedicine in some parts of the state, because we just have such a huge shortage of people who are trained to provide this really needed service.
Mr. McDonough.
Mr. Chair, Representative Loeffler, that conversation was a large part of the Governor's Mental Health Task Force, recognizing that in all areas we've got gaps in the continuum, whether it's physical sites to actually house or provide services for individuals with mental health, but also large gaps in the professional fields to support that. And we need to make sure that we're bringing this along together. And as we build capacity within the system for places to provide that support, we're also working in many areas to provide capacity in the workforce to support those investments.
Thank you, Mr. Chair.
Representative Schultz.
Thank you, Mr. Chair. I just want to thank Representative Albright for bringing forward this bill, and for the contributions of NAMI and Sue Abderholden for working with my county, St. Louis County, on developing a plan, and to allow to have flexibility in the bill for not just facilities but support services, and really addressing what the communities need rather than putting a more structure on that. So thank you.
All right. Further questions? All right. Seeing none. Representative Albright, final word.
Thank you, Mr. Chair, for the opportunity to present the bill to you.
All right. With that, House File 2274 is, I guess, it's just here as amended.
Information.
It's a good place to be.
Thank you.
Thank you, Representative Bucci. All right. Yep. All right. Last two bills we're going to hear tomorrow. With that, we are adjourned.